Hi there, our highly valued, treasured and esteemed viewers and listeners, and welcome back to your channel of choice. This video I am about to present was compiled by Dr. Nath Arua, a clinical pharmacist by training and profession who is the founder of Progressive Pharmacotherapy Consultants, the premier virtual clinical pharmacy institute for capacity building for healthcare workers. The Virtual Clinical Pharmacy Institute with a difference, where patient safety, medication therapy management and optimal clinical outcomes are very crucial and non-negotiable to us. Here we seek to remain your premier source of crucial tips for high-impact pharmacotherapy services. So, on behalf of the Institute, I humbly urge you all to sit back and spare me part of your very precious time to share with you very useful tips which may prove very, very handy in your line of duty. I now welcome you all to part 384 of our pharmacotherapy series, which majors in pain and its management. The first question of this case reads: TMT is a 33-year-old woman with chronic abdominal pain. She first experienced recurrent episodes of abdominal pain at the age of 13 after menarche. At age 21, she was diagnosed with acute pancreatitis secondary to alcohol use. Her pain has persisted despite numerous trials of medications including gabapentin, sertraline, tramadol, and hydrocodone co-formulated with acetaminophen. She has undergone multiple diagnostic evaluations for the abdominal pain, but all have resulted in negative findings. During the past year, TMT has had 8 visits to the emergency department for severe pain, where she usually receives IV hydromorphone and then is discharged with a week's supply of oxycodone co-formulated with acetaminophen. In addition to the emergency department visits, she has been hospitalized 3 times in the past year for abdominal pain. Today, TMT is being seen in the clinic by her primary care physician for continued management of chronic abdominal pain, which she describes as constantly aching. Over the past 2 years, TMT's primary care physician has been prescribing oxycodone in conjunction with an opioid agreement focused on minimizing the use of emergency department visits for pain management. TMT believes her current management with oxycodone 5 mg by mouth every 4 hours as needed for severe pain is insufficient, and would like the 30-day supply limit increased from 180 to 240 tablets. The primary care physician is concerned about TMT's functional status since starting opioid therapy. There has been no noticeable improvement in TMT's pain, despite 3 increases in the 30-day oxycodone supply over the past 2 years. During the office visit, TMT is emotionally labile at times and tearful when discussing her pain, but is emphatic that she is not depressed. She states that she drinks 1 or 2 highballs, that is whiskey and soda, about 2 times a week to help her relax when she is feeling stressed out. TMT denies smoking or illicit drug use. She is currently unemployed and seeking permanent disability because the pain interferes with her ability to work. Her physical examination is unremarkable except for diffuse abdominal tenderness. So my question to you reads: what is the clinical relevance of TMT's self-description of abdominal pain? Regarding the clinical relevance of abdominal pain, TMT's self-report of pain is consistent with functional abdominal pain, abbreviated as FAP. Functional abdominal pain is more common in women and peaks around the fourth decade of life. Patients with functional abdominal pain have high work absenteeism and healthcare utilization. Key features in the diagnosis of functional abdominal pain include abdominal pain that is present for at least 6 months and is not related to gastrointestinal function. The patient will often have a decrease in daily activity with time. The principal criterion differentiating functional abdominal pain from other gastrointestinal disorders, such as pancreatitis, is constant pain that lacks symptom relationship to food intake or defecation. Psychological disturbances are more likely when pain has persisted for a long period and manifests as symptom-related behaviors that dominate a patient's life. From the physiologic perspective, TMT's abdominal pain most likely originated from a combination of somatic and visceral components associated with menses and pancreatitis. When the pain symptoms occur frequently in conjunction with a stressor, as in functional abdominal pain, the main mechanism for altered pain regulation relates to the failure to inhibit the amplification of normal regulatory afferent input from the gut to central mechanisms in the prefrontal, cingulated cortex, and limbic structures, e.g., cognitive and emotions centers of the brain. This impairment in homeostatic inhibition of pain may be related to low levels of serotonin, norepinephrine, endorphin, and other neuropeptides that mediate descending pain transmission in the CNS. Recognition of the brain-gut axis in functional abdominal pain is essential to understanding its clinical presentation, diagnosis, and therapeutic strategies. My next question to you reads: what are the current recommendations for pharmacologic treatment of functional abdominal pain? What approaches to the management of functional abdominal pain are appropriate for TMT? Pharmacotherapy for patients with functional abdominal pain is empirical and not based on results from well-designed clinical trials. Clinical trials have not been targeted to this diagnostic entity, so treatments are typically designed on the basis of data from other chronic pain disorders. The cornerstone to management depends on an effective relationship between the clinician and patient. In this case, the primary care physician needs to listen to TMT's concerns, but set realistic and consistent limits when ordering tests, medical interventions, and medications. TMT needs to be an active participant in the pain management plan and take responsibility for self-care. Antidepressants, such as tricyclic antidepressants in low daily dosages, may be useful in treating functional abdominal pain for both pain and depression owing to their combined noradrenergic and serotonergic effects. In other chronic pain conditions, tricyclic antidepressants generally have been more successful than using selective serotonin reuptake inhibitors. Medications with combined serotonin and norepinephrine reuptake activity, e.g., serotonin and norepinephrine reuptake inhibitors such as venlafaxine and duloxetine, have recognized pain-reducing effects with somatic pain conditions and may be useful in functional abdominal pain. To ensure treatment adherence, TMT needs affirmation that antidepressant is not prescribed simply to treat depression. It is important that the clinician educate the patient on the role of antidepressants in the treatment of pain. Patient education resources such as diagrams help to show the physiologic basis for treatment of pain and describe descending inhibitory pathways. Gabapentin and pregabalin clinical trials have established their efficacy for neuropathic pain and fibromyalgia, but benefit for visceral or central pain syndromes is not established. Non-steroidal anti-inflammatory drugs offer little benefit because their action is located in the peripheral nervous system. Long-term treatment with benzodiazepines is not recommended because of the abuse potential and tendency to interact with other medications. For patients who are refractory to usual doses of antidepressant medication, referral to psychiatry should be made for treatment with atypical antipsychotic agents such as quetiapine. There is concern about TMT's use of alcohol and escalating use of opioid medication. So my next question to you reads: what is the risk that TMT will become addicted to opioids? Opioid use behaviors are stratified based on the risk of aberrant drug use. Aberrant drug use behaviors may occur along a spectrum from those less suggestive of addiction, such as an occasional, sanctioned increase in the opioid dose by a medical provider, to those that may be more suggestive of addiction, such as injecting oral formulations. Important but less consistent risk factors include pain-related functional impairments such as sleep disturbance, mental health issues, history of child sexual abuse or neglect, and legal problems. With respect to gender, women with chronic pain who report significant emotional issues were at increased risk for opioid misuse. TMT has multiple behaviors in which some are more indicative of addiction, such as concomitant alcohol use, whereas others can be explained given the etiology of functional abdominal pain. For example, high healthcare utilization for pain validation is common in patients with functional abdominal pain. Also, aggressive complaining about the need for more opioid medication may be driven by TMT's perception that the current dose prescribed by her primary care physician no longer relieves her pain, implying tolerance has developed. The factor that is most concerning for addiction is TMT's continued use of alcohol despite previous pancreatitis and misusing it to treat anxiety. There is also a risk of increased opioid side effects, especially sedation and respiratory depression, with concurrent use of alcohol. Multiple literature reports have confirmed there is a strong association between alcohol abuse and opioid addiction. Guidelines for chronic opioid therapy strongly recommend clinicians conduct a risk assessment of substance abuse, misuse, or addiction before initiating opioid therapy. TMT would like to continue with opioid therapy despite the concerns of her primary care physician. So my next question reads: is TMT a candidate for chronic opioid therapy? The Centers for Disease Control released new recommendations for opioid therapy that support the establishment of a treatment plan with the patient before starting opioid therapy that includes realistic goals for pain and function along with consideration of when therapy will be discontinued if benefits do not outweigh risks. Clinicians should continue opioid therapy only if there is clinically meaningful improvement in pain and function that outweighs risks to patient safety. In the case of TMT, a pain agreement, e.g., contract, should be established even if the goal is to eventually discontinue opioid therapy. There are multiple sources in the literature for information and guidelines on written agreements between the clinician and patient for chronic opioid therapy. The written chronic opioid therapy agreement should include goals of therapy, how opioids will be prescribed and taken, expectations for follow-up and monitoring, alternatives to chronic opioid therapy, expectations regarding use of concomitant therapies, and potential for tapering the regimen and discontinuing. Indications for tapering and/or discontinuation of the opioid include failure to make progress toward therapeutic goals, intolerable adverse effects, or repeated or serious aberrant drug-related behaviors. Patient compliance requirements within the written agreement should include random urine drug screens for illicit substances or opioids obtained from other sources and limited prescribing, e.g., reduced quantities, or biweekly prescribing, to help the patient manage use if necessary. In this case, TMT has not made progress in meeting the goal of decreased emergency department utilization. She continues to use alcohol with her medication, and she has been resistant to trying other therapies despite the ineffectiveness of opioids in treating her pain. These behaviors would indicate TMT is not a candidate for chronic opioid therapy. Screening tools that assess the potential risks for opioid misuse based on patient characteristics are helpful in determining eligibility for chronic opioid therapy. Patient self-report questionnaires for assessing risk of aberrant drug-related behavior include the Screener and Opioid Assessment for Patients with Pain Revised, abbreviated as SOPAR, and the Opioid Risk Tool, abbreviated as ORT. The Diagnosis, Intractability, Risk, Efficacy, abbreviated as DIRE, tool is a clinician evaluation instrument designed to assess the potential efficacy of chronic opioid therapy as well as harm. In TMT's case, her diagnosis, intractability, risk, efficacy score is 10, which would indicate she is not a suitable candidate for long-term opioid therapy. TMT is going to be discontinued from opioids as part of the pain management plan. So my question to you reads: what methods are appropriate to safely discontinue opioid therapy in TMT? Guidelines strongly recommend that clinicians taper patients from chronic opioids if they have repeated aberrant drug-related behaviors, experience no progress toward meeting therapeutic goals, or experience intolerable adverse effects. When tapering patients from long-term opioid therapy, the length of time the patient has been taking opioids needs to be considered. Approaches to opioid tapering range from a slow 10% dose reduction per week to a more rapid 25% reduction every few days. Evidence to guide specific recommendations on the rate of reduction is lacking, although the slower rate may help reduce the unpleasant symptoms of opioid withdrawal. There is insufficient evidence to guide recommendations for the use of short-acting versus long-acting oral opioids, or as needed versus around-the-clock dosing during taper. In this case, it is recommended that TMT's oxycodone dose be reduced slowly over 2 months in conjunction with starting psychological therapy for stress management and counseling for alcohol use. TMT will need to be monitored for signs of withdrawal, which include anxiety, tachycardia, sweating, and other autonomic symptoms. Should withdrawal symptoms occur, They may be lessened by clonidine 0.1 to 0.2 mg orally twice a day. The next question reads, what non-pharmacologic therapies could be offered to TMT to help with her pain management? Psychological counseling and cognitive behavioral therapy are key components to successful management of the patient. The psychological approach to cognitive behavioral therapy has been shown to be beneficial in the treatment of functional abdominal pain. Cognitive behavioral therapy typically combines stress management, problem solving, goal setting, pacing of activities, and assertiveness into a strategy for self-management of pain. Biofeedback, meditation, guided imagery, and hypnosis can all be incorporated within a cognitive behavioral therapy plan. The objective is to help patients acquire a sense of hopefulness and resourcefulness, and develop positive coping skills. Complementary and alternative therapies such as spinal manipulation, massage, and acupuncture are commonly used in patients with chronic pain, but data supporting their use in FAPS are limited. Transcutaneous electrical nerve stimulation has been tried in FAPS patients, but the results are inconclusive. So there you have it, our highly esteemed viewers and listeners. That brings us to the end of this video. If it benefited you in any way, kindly remember to give it a thumbs up, to like it and to share it widely with your peers. Please leave your comments at the bottom. And if you haven't yet done so, I humbly urge you to subscribe to our YouTube channel. I would like to promise you all that the very, very best is yet to come. Thank you very much for viewing this video. On behalf of our senior colleague, Dr. Nath Arua, I sincerely appreciate your partnership, continued support and kind collaboration. We look forward to interacting with you in the next video, which will be part 385.